Welcome to University of Kansas. My name is Tim, and today we are very glad to have invited our special guest, Dr. Carolyn Schroeder, one of the established figures of pediatric psychology, to share her experience and expertise in this field. So, Dr. Carolyn, would you mind to first introduce yourself first?
Yes, I'm Carolyn Schroeder. I'm a pediatric and clinical child psychologist, and I'm currently an adjunct professor here at the University of Kansas, and I'm also program director for an organization, Annie Sullivan Enterprises, which focuses on providing services and helping professionals who work with children with developmental disabilities.
Yeah, thank you. So, how about let's talk about the history parts first. Yeah.
Sure.
I noticed you that you received your PhD in University of Pittsburgh
Yes.
in 1966, right?
Yes, a long time ago.
So, do you already develop your interest in pediatric psychology at that time?
Well, it was a very difficult time in terms of what was going on in psychology in the 60s. We were clinical psychologists, but most of the focus was on a psychoanalytic approach. And they tried to translate that into learning theory. So that was Dollard and Miller did that, so that psychologists would feel more comfortable with it. But there wasn't a specialty of clinical child psychology yet, nor even the harbinger of pediatric psychology. But there were people very interested in what psychologists would have to offer to children with medical issues. And so my interest came over really a period of time, and particularly increased when I did an internship at Pittsburgh Child Guidance, and it was the head of psychology at Pittsburgh Child Guidance was Alan Ross, who is really considered to be the father of clinical child psychology.
So did he inspire you or not, become your role model?
Well, in a way, he inspired me, but to be honest, when I was working and doing my postdoc at the Child Guidance Center, I was very concerned that we were not looking at the effectiveness of our strategies with children. And at that time, Todd Risley and Montrose Wolf, all people who later came to the University of Kansas, they were at the University of Washington at the time, they began doing work with applied behavioral analysis, behavior modification, so forth, behavior therapy. And it was their work with children, their single subjects design, that we all started reading. And Dr. Ross, who really had been very much a psychoanalyst up to that point, became very involved in that area. And we ran a seminar on it, and he later left the University of Pittsburgh and went to the University of New York at Buffalo, not Buffalo, at, lost really. But anyway, he left and became a very avid person for behavior modification. And also at the University of Pittsburgh, we had Peter Lang and Dave Lazovic, who did the first work on demonstrating the use of classical conditioning. Yes, with really desensitization for a therapy, and demonstrated that it was empirically sound. So I had those beginnings with it. So I would think that Dr. Ross was an influence, but Dr. Lazovic was also a very big influence. And then I would say Todd Risley and Malt Wolf, and actually Michael Rudder, who's a psychiatrist in Britain, who's just a wonderful person with developmental issues and looking at people over their trajectory of their life. So I would say those were really my mentors early on in my training.
Okay, oh, very impressive. Yeah, so when we talk about the early years, I noticed one of your articles, you mentioned that few decades ago, children who have to refer out or did not receive early intervention due to the reimbursement system or other factors. Yeah, so how is that changed over time?
Well, I think what I was speaking about at that time was that in primary care practices where most parents ask their pediatricians or their family doctor about concerns on development or emotional issues, that often they were referred out of the clinic to receive their services. And many of them did not follow through on those referrals, or they could not find people who were really trained to treat those issues. And if they found people, often the insurance companies did not cover those services. So it was a confluence of factors that made it difficult for parents, particularly of young children, to get early intervention and prevention. Often the adage was, they'll grow out of it. Let's wait and see.
Okay.
They're too young to do anything about it, which we now know is not true.
I got it.
But I think that it has changed. People are far more aware of the need for early intervention of children, and I think it's become a really important issue. The issue now is really more funding.
Many more funding,
Because this is a population that is often ignored in terms of reimbursement unless they have severe problems. And we're talking about early intervention, not just with severe problems, but even minor problems that can become severe or interfere with the child's functioning if it's not dealt with.
Yeah, especially as the time go on, the legislation, the IDEA, and also the assessment tool and the screening method has advanced.
Yeah, it's developed tremendously. So we have better screening.
Yeah.
We have better ideas of what kind of intervention works, at what age, and with what populations.
Yeah.
We understand the importance of parents actually being involved
Yeah.
in the therapy, not just going to a workshop, but actually demonstrating with their child the therapeutic techniques. And so often we see with early children, I would consider myself really a consultant, not a therapist, only in the sense that I'm trying to use my skills to teach the parents how to work with the child.
Yeah.
And other significant figures in the parent's life.
Okay. So in later 1973, you became the co-founder of Pediatric Psychology of University of North Carolina in Chapel Hill.
Well, that's not quite exactly the name of it, but when I went to the University of North Carolina in 1968, I went there to work in a clinic called, it was a Division of Disorders and Development and Learning. And that was a clinic that was funded by the federal government through the university affiliated program. And the focus of that, our work there, was to train disciplines, all kind of healthcare disciplines, in dealing and working with children with developmental disabilities. So we had, at that time that I went, 12 different disciplines represented in this clinic, and students from all those disciplines. So we had chaplain, we had nutrition, physical therapy, occupational therapy, you name it. You have the entire range of healthcare professionals. And our goal was to train people at the graduate and particularly the postgraduate level to work with all of the disciplines and to learn what each discipline specifically had to offer for the development of that child that we were focusing on. And therefore, people from physical therapy had to work with psychologists to understand. We had to work with them and our students. So my concern was that our students were seeing the trajectory of a child's development and a child who had developmental disabilities, and they often thought that that developmental process was specific or peculiar to a child with disabilities.
Yeah.
And a nurse and a social worker and I decided we wanted to have our students experience and work with parents of children who did not have any disability or known emotional issue. And we went to the local and only pediatric office in Chapel Hill. It was a community pediatric office. And we said, we would like to offer some services in your clinic, and we'll offer them free, but we want to be able to train our students. And the students specifically we wanted to train were pediatricians, psychologists, nurses, and social workers to start with. And so the pediatrician said, oh, that's really a pretty good idea. What we need is for you to answer parents' questions about development or early issues, because we get calls all the time and we don't always have the answers. And we said, well, that sounds good, but at that time they wanted us to do it on the telephone. And we were like, a telephone in 1973? You are kidding, we're not allowed to do that. But they said, no, we do it all the time. You can do it. These are not people who have major issues. But we said, well, let's just ask the parents what they want. And they said, fine. And we did a survey of 100 parents with children under 3 and under. And out of that survey, we called them up and asked them if you had some services on your child's development or emotional issues, what would you like them to be in the pediatric clinic? And they came back with it like parent groups. They would definitely like in a call-in, specific call-in times where they could call in and ask questions about development and learning. And they would like an opportunity to come in if they needed to come in. And we decided the other thing we wanted to offer, which the pediatricians agreed with, was to do screening. And we did screening of children at 36 months. And later we backed that up to 24 months. And in that area we trained the nurses in the clinic to do the screening, and then we had nursing students and public health nurses come and work with them and help with the screening and learn what results could come from that. So those were the services we offered in 73, and it was primarily for training, but we had parent groups once a week, actually twice a week. We started out, and that was every month we would focus on a different age or stage in development.
A different topic.
A different topic, so it might be like the 3-year-old, and so you might go through the whole range of issues that 3-year-olds were having. And parents would come in the evening, and we also had an afternoon one, which never got full. But the evening, we sometimes had to have break them into two separate groups because of the interest. And that service is actually continuing to this day. And we've actually taken it down to parents of newborn children up to 18 months, where that's an ongoing weekly session. And the pediatricians love it because many of the issues that come up with feeding and sleeping and eating and support, the parent support, is very important. So those services continue, as does the call-in service. Parents can call in, and that's scheduled twice a week for an hour, twice a week into the practice.
I think this is a fantastic job and contribution,
Well, it was a new thing, but we did it for training, but the parents loved it so much, and the pediatricians found it so helpful, that in 1980, I received a sabbatical and to work in the pediatric office during that year, and I did. I went and set up a little practice in the office, and our goal there was to see, would parents use the services?
Yeah.
Because we learned from our call-in hour that 17% of our parents who called in, we referred out for further evaluation.
Oh.
Because the problem was such that it was worrisome and we felt they needed. But very few of those people followed through. And they said, we want the services in the practice. They didn't want to go to somebody outside the practice. So that's what I did on my sabbatical. And then I went back to the university for a year.
Okay.
And then in 1982, I decided to go full-time.
Yeah.
And I left a tenured position at the university in both pediatrics and psychiatry to go full-time in Chapel Hill Pediatrics, which is a community pediatric primary care setting. Now, the university gave me a clinical appointments in pediatrics and psychiatry, and actually all of the pediatricians in the practice also had clinical appointments in the Department of Pediatrics. So it was a very interesting mix of people at that time.
Yeah, and I noticed that at that time you have become a strong advocate for interdisciplinary service for children. Yeah, is it from your practice, this idea?
Oh no, I think it became very clear. Even in my internship, we had, in a child guidance center, we had social workers, psychiatrists, and psychologists as the main team. But working in the developmental clinic, I just realized the importance of all the different disciplines and what they had to offer, and that there was no way I could begin to offer those services. But I could recognize when a child needed language therapy, okay, or versus speech therapy even, that's a difference. Or I could recognize when a child needed an occupational therapy evaluation, or that perhaps that would be helpful. Or so I was able to draw upon my knowledge from working in that clinic and with those disciplines to recognize that no discipline really stood alone in meeting the needs. We needed a variety of disciplines, and not every child needed every discipline.
And give them a choice.
But they, yes, and also to say, this child really is having difficulty with fine motor skills. Let us look at what occupational therapy might be able to help. So that's where my interest in interdisciplinary, and I firmly believe that that is, particularly in pediatric psychologists and psychology, we are very much aware. I think the whole Society of Pediatric Psychologists is very much aware of the importance of other disciplines.
I also noticed that, we really highly value this interdisciplinary service, but at the same time, it seems there's a lot of difficulties, a challenge when it comes to real practice. Is it?
Yes, I think that is. It's a very good point. And working in Chapel Hill Pediatrics, you know, I quickly learned about all of the different services in the community, and particularly those services that were free or early intervention or screening. So what was available in the community? Because finding people who knew about child development in the community at that time, and I still think it's true to some extent, who could follow through with a child was difficult. And I think the insurance is also always a big issue. How does it get paid for? So, you know, when we have programs that are run by the state or the federal government, it's far easier to move your families into those programs, particularly with young children, than to provide those services on a private basis. So a lot of it has to do with finances and resources.
Yeah. Okay. And then later on, during the 1977 and 1978, you were selected as the president of the Society of Pediatric Psychology. So, let's talk about it. During that year, is there any unforgettable or exciting moments in this field?
Well, again, we were a very young society at that time, very young, and there were not very many of us. And most of us came from developmental disability clinics focusing on children with developmental disabilities. So you had people like Diane Willis and Jean Walker. Now Logan Wright was also at the University of Oklahoma Health Science Center. It was probably one of the premier place for training of pediatric psychologists, and that was where Logan Wright was, and Jean Walker and Deanne Willis were there, and then Phyllis McGrath was at Georgetown. But these people all had some experience with looking at children along a developmental continuum, as well as looking at developmental psychopathology, and they all had experience with interdisciplinary issues. So it was a very exciting time, and I think one of the most exciting things that happened during that tenure over my presidency, really happened a little before, was the beginning of the Journal of Pediatric Psychology, and it's really a superb journal. And that really began as a newsletter, and then became so important. I don't remember the exact year. I think it was 76 or 77. 76, I think, the journal came into being. So that was a really important time, and I think during that, just promoting it, and then it was, we had a guild, the society, and now we had a way of disseminating our work. And we had the beginnings of providing some opportunities to do research and have that disseminated. So that was a very heady time. But we were very poor as a society, and communication was often difficult because we did not have the internet. It was all by phone or mail. And but we had wonderful meetings, and those were often done in the president's home, and where they hosted all the rest of the board, sleeping there or sleeping nearby. And we were all very, very enthusiastic people. So it was probably one of the most exciting times of my life.
That's lovely. Okay, so when it comes to the practice problems, I noticed one of your article, you described the chronic illness is only account 2% in the Chapel Hill service.
Oh, the chronic illnesses of children. Yes, I think that surprised me a bit. Having worked in Department of Pediatrics, I was expecting to see more children with chronic illnesses. But in reality, given that we were next to a wonderful medical school and hospital, University of North Carolina Medical School, that really was a tertiary center, and the children were referred there for their asthma treatment, for other kinds of treatment, but not the behavioral. That is what we focused on in the pediatric office. We focused on a lot of emotional, behavioral problems, but we also dealt with some chronic illnesses such as cystic fibrosis, even though they were being treated at the medical school. We really worked with the parents on emotional issues and things like eating problems, or asthma, the same types of things. We became a support for parents and children. And the attention deficit disorder, hyperactivity,
ADHD.
that was a very big issue in our practice. And we worked closely with the pediatricians, and that was this is a wonderful example of funding that we really felt that before any child should be put on medication, that they should have a thorough psychological and educational evaluation before any medication. And then if they were put before medication, that other methods, behavioral methods, should be used to help the child. And if they were put on medication, that they would be put on a trial basis. And we actually had a placebo double-blind trial where the medication was made up by the pharmacist, and the parents did not know, nor the teachers, nor the person evaluating them, whether the child was on placebo or low or high dose for their weight. And they were evaluated by the school and the parents and in clinic over a 3-week period, and then we broke the code to determine was it effective or not. Well, the insurance companies became so impressed with our approach that they actually funded it. They provided the funds for the evaluations and for the follow-up for the parents. And we discovered that many children did not need medication, and those parents who were loath to give medication when they saw our results, or the results of the 3-week trial, were very happy to do it. They could see the changes. So that was an example of where ADHD is now considered a chronic, long-term problem, where we did enter into it. But for the most part, I mean, we did have the child who had cancer we were supporting, or the family. But a lot of those services were really offered in the hospital. And that's the value of having psychologists right in the hospital and working with a team of physicians and other people.
Okay, I get it.
Yeah.
So now let's talk about the future issue and the training. Yeah, in your opinion, what do you think are the maybe three main issues in the pediatric psychology that you think is urgent and important for study?
For starting, well, I think I think the training is a critical issue. Training. I think that we have excellent training programs for clinical child, but I think the experience that a pediatric psychologist needs goes beyond what a clinical child person has. They need training more in interdisciplinary work. They need more understanding of the disease process and the medical. They need opportunities to work and have practicums in medical settings. And I think that is a challenge at all levels, undergraduate, graduate, and postgraduate. And perhaps not so much anymore on the internship and the postgraduate, but the training in graduate school is crucial. And there's not enough time to provide all those courses or services. So I think that's a challenge because a person needs to know about developmental psychopathology. They need to know the lifespan approach, a developmental lifespan approach. They have to have a good developmental background. So it goes beyond the clinical child program. And there are very few programs in the country who offer enough of these opportunities. And I think the University of Kansas, under Michael Roberts' tutelage, has definitely expanded in that area and offers those opportunities. But that's a rare. So I would say training, and training not only in opportunities for practice, but also research. Very important thing. And I think the other area I think that is crucial is that pediatric psychologists have a very important role to play in primary care settings. And we have not succeeded in doing that at a very high level. And people have difficulty working in primary care settings, and I think that we are being left behind, and we're having social workers and people with other degrees working in those settings, and because they are not paid as well. And I think the other thing is these settings do not realize the value that a psychologist has to bring to the practice, not only in clinical work, but in letting data drive the practice and the questions. So the research and also just the collection of programmatic data that guides what you do. I don't think that they understand the value of where psychologists can deal with training issues, can deal with problems within the clinic, personality problems, or how to offer services at the best and most efficient level. I think pediatric psychologists have a lot to offer primary care, and we need to find more ways to get psychologists into those practices, as well as find ways to fund them more effectively in those practices, because many of the services offered in primary care are actually free. They're free to the parents, and the consultation is free to the pediatricians and other people in the community, in effect. And how does that get paid for? So that's a big issue. And another issue within primary care is we need to have better data on the effectiveness of having mental health and behavioral issues handled in primary care. We need more data on how effective are you in preventing long-term. I mean, we certainly kept data on our children and families, and we know that we saw parents on the average or for a problem maybe 5 times. And we know exactly how many times on the average it's going to be if you have an anxiety problem versus a behavioral problem. But we need more systematic data, and we need it from more practices. And that's what we'll demonstrate to the pediatricians, and the medical profession and the insurance companies that we're effective. They want to know, well, why would we hire you versus somebody else? Or why can't we as pediatricians provide those services? Or we can send them out for those services. So I think that's a very big challenge we have to face. And it was a challenge that actually Logan Wright gave to us in 1967, saying, we need to be on the forefront, out in community pediatric practices. In 1967, he said, you're going to see more patients with less severe problems, and you're going to see them for less time. And he was exactly right. But that's a promise that we haven't fulfilled in our society. So I see that as a big issue.
And an opportunity.
An opportunity and a challenge, but figuring out, I mean, I worked in the practice, 30, 40 years almost, close to 40 years, and people were always interested in what we did, but it appears to me that it was a unique situation where we had a wonderful university with a public health department, a school of public health that was well known, and they supported our work tremendously, Dr. Arden Miller. We had a wonderful Department of Pediatrics with Dr. Floyd Denny and Dr. Harry Chamberlain. We were doing work in the community with many of the physicians were aware of the importance of psychology and other disciplines played in their work. And therefore, even though this was a private practice, there was tremendous support for us doing research in the practice, for training. The parents liked it. So it was a unique confluence of things that came together at the right time. But I think that could be done in other communities, and I think others have done it, but we're few and far between.
Yeah, and we need new generation of pediatric psychologists.
Yes, who are primary care people.
Yeah. So finally, could you give us some advice on the new generation of pediatric psychology?
On the what?
On the new generation of...
The new generation? Well, I think the new generation is exciting because they're being trained earlier, and we have so many wonderful role models. I think of Denny Schroeder's program at the University of Cincinnati.
Yeah.
I mean, it's just a wonderful program. And so there are opportunities there. I think the new generation is going to be more interdisciplinary. I think they're going to be perhaps apply their clinical skills in more areas than hospitals, I hope. And I think pediatric psychologists, more than any other clinical group, is going to know research and clinical work very well.
Yeah.
And they're going to they are good researchers, most of them, but how to do that within a clinical setting is what is going to be the challenge. But I think this next group will do that.
Yeah, okay. And finally, thank you, Dr. Carolyn's precious time to do this interview, and we hope you all the best.
Oh, thank you very much.
Thank
It was a pleasure to do it.
Yeah.